My name is Professor Barbara McGowan. I'm a consultant endocrinologist and obesity physician at Guy's and St Thomas's Hospital, where I'm also Professor of Endocrinology and Diabetes. So the STEP 10 trial was really put together to investigate the effects of semaglutide 2.4 milligrams, specifically in a population of people living with obesity and prediabetes. So we've had trials, of course, investigating semaglutide 2.4 milligram for weight loss, but this was in a specific population. So in terms of the study design, this was a randomized, double-blind controlled trial, multi-centered. So the key inclusion criteria for the trial included adults aged 18 and above with a BMI of 30 and above. And all patients had prediabetes as defined by NICE, that's an HbA1c between 6% and 6.4%, and or a fasting plasma glucose between 5.5 millimoles and 6.9 millimoles per litre. And they recruited 207 patients, which were randomized in a 2-to-1 fashion to either semaglutide 2.4 milligram once a week or placebo. And there was a dose escalation period followed by a maintenance period up to 52 weeks. And during this time, all patients received lifestyle intervention, with dietetics advice and physical activity advice. At the end of the 52 weeks, there was an off-treatment period up to 80 weeks where patients received just healthy lifestyle counselling as per normal clinical practice in the country specific to where they were doing the trial. Now, in terms of the key endpoints, the primary was weight loss at week 52, and also the proportions of participants that reverted to normoglycaemia. In terms of secondary endpoints, at week 52, there was changes in HbA1c, fasting plasma glucose, waist circumference, systolic blood pressure, and other cardiovascular markers, as well as categorical weight loss. And some other exploratory endpoints, which looked at reversion to normoglycaemia at week 80, and also the progression of type 2 diabetes, both at week 52 and at week 80. Now, in terms of what did the patients look like, they were mostly female, 31% female. The average age was 53 years, and the majority were white, 88%, and the rest Asian, Black, and other ethnicities. The mean body weight was just over 111 kilograms, and with a mean BMI of just over 40, and the waist circumference of 120.1 centimeters. At baseline, the mean HbA1c was actually 5.9%, as well as the mean fasting plasma glucose, which is 5.9 millimoles per litre, and the mean blood pressure, which was 131. So the first primary endpoint was a change in body weight. And what we saw was that at 52 weeks, there was a much greater decrease in body weight in the semaglutide 2.4 arm of 13.9% compared to 2.7% at 52 weeks in the placebo arm. If we looked at the categorical body weight loss, all the categorical weight losses, that's 5%, 10%, 15% and 20%, were greater in the semaglutide 2.4 milligram group compared to placebo. So about just under 50% achieved at least 15% of weight loss in the semaglutide 2.4 arm compared to only 1.5% in the placebo arm. And just under a quarter, so 24.8%, achieved 20% weight loss in the semaglutide arm compared to the placebo arm. In terms of the other important primary endpoint, which was the reversion to normoglycaemia, this was achieved in just over 81% of patients in the semaglutide arm compared to only 14.1% in the placebo arm. And this was at 52 weeks. Now, at 80 weeks, when the medication was stopped, this sort of reduced the reversion to normoglycaemia to 44%, 44.2% actually, in the semaglutide arm, compared to 18.3% in the placebo arm. What we also saw was that, there was a greater reduction in waist circumference in the semaglutide arm at 52 weeks. So a reduction of minus 0.83 centimeters in terms of estimated treatment difference compared to the placebo. And again, a reduction in blood pressure with an estimated treatment difference of 7.8 millimoles per mercury at 52 weeks. But what we did see that when you stop the medication at 52 weeks, there was an increase in the waist circumference, towards the baseline, as well as the blood pressure, which tended to increase back to the baseline. In terms of HbA1c, again, there was a reduction with an estimated treatment difference of minus 0.5% from the baseline, which was 5.9% at 52 weeks. And also a reduction in fasting plasma glucose of 0.6 millimoles per litre at 52 weeks in the semaglutide arm, compared to only, compared to the placebo arm. But again, after 52 weeks, there was sort of a regression back to baseline for both HbA1c and fasting plasma glucose. So the take-home messages for this trial, it's that semaglutide 2.4 milligram again showed superior reduction in body weight and reversion to normoglycaemia compared to placebo, as well as improvements in other cardiometabolic risk factors, waist circumference, blood pressure, which is obviously very encouraging. In terms of the safety profile, which I didn't mention, it was consistent with that of the rest of the GLP-1 receptor agonist class, so no new adverse events. So everything was as we know thus far. And so these results really add to the existing evidence of the benefits of obesity management, the progression of prediabetes. And using these medications can help us to sort of slow down that sort of progression to type 2 diabetes. So the next steps, I guess, is to probably to start early in the journey. I think obviously, weight loss is beneficial in patients with prediabetes. So I think we need to look at prescribing semaglutide 2.4 milligrams or earlier on, during the journey. And I think, talking to payers perhaps to say, look, we want to prevent type 2 diabetes. Let's intervene earlier in the journey, because we know that prediabetes is prevalent and associated with an increased cardiovascular risk, so it's important to treat it. Well, the challenges are, one is that I guess obviously there's a cost associated with the medication, and also there are global supply issues with the medications, and there are across the globe, many patients living with both obesity, but also pre-diabetes, somewhere between 6 to 9%. So I think this is the challenge that we have at the moment. And we need to ensure that we keep talking to our commissioners to emphasize how important it is to treat obesity and its complications early, because in the long term, this is a cost-effective exercise, and preventing the complications of diseases such as prediabetes and type 2 diabetes will inevitably lead to a healthier nation and to cost savings. But it is challenging, of course, right now.